Welcome back. This is the morning show here on Signature TV. It's 9:12 in the morning on the 4th of June 2025. Hope you're good out there. Today we're switching gears a little bit to something in health. All right, and it's about Clubfoot syndrome amongst newborn babies in Nigeria. And we have with us via our upside studio in Birnin Kebbi State this morning, a consultant orthopedic surgeon, Federal Teaching Hospital, Birnin Kebbi. Good morning. Thank you for joining us, Dr. Anipole Akeem.
Good morning, sir.
Thank you for your time. Truly appreciate. What exactly is Clubfoot syndrome, and how does it develop on the newborn?
Thank you very much. Clubfoot is otherwise known as congenital talipes equinovarus. Congenital in the sense that the babies are born with it. Talipes is a word meaning the ankle, and pes is foot. So congenital talipes equinovarus clubfoot is a condition in which children are born with a foot deformity that appear in which the foot appears downward and inward, like you have a golf stick. That's congenital talipes equinovarus that we generally call clubfoot. There are different types of clubfoot depending on the criteria for classification. But generally speaking, I will divide it into two for the purpose of this discussion. There's one we call idiopathic clubfoot, in which the cause is unknown and usually found in a patient that are otherwise normal. Every other thing in this baby is okay congenitally, except such in a baby, it is described as the idiopathic clubfoot. And this is the commonest type of clubfoot that is found in more than 80% of patients or babies born with clubfoot. The other ones that are generally called secondary clubfoot, where you also have the syndromic clubfoot, that form less than 20% of them. This occurs when patients or babies with clubfoot also have associated congenital anomalies or associated congenital problems. This is the one that's we call syndromic clubfoot. This actually forms a small subset of the clubfoot, but the major subset of the clubfoot is the idiopathic clubfoot. Thank you.
Interesting. What for you are the early signs or symptoms of clubfoot, and how do you think is it prevalent on largely for women who haven't done antenatal so well? Do you think a consistent antenatal or a consistent screening help with checking clubfoot on babies?
The prevalence of clubfoot worldwide is between 1 and 2 per 1,000 live birth, meaning that 1 or 2 out of 1,000 newborn babies would have clubfoot. And black people, the incidence seems to be higher. In Nigeria, it has been reported to be as high as 3.4 per 1,000 live birth. So that's the prevalence. Usually, tends to be common among the male than female, taking a ratio of 2 to 1. It usually affects the right lower limb, but you could have it affecting both lower limb in about 50% of cases. Clubfoot, the one that I talked about, the idiopathic clubfoot. Like I said, the cause is not known. It's not the mother's problem. It's not due to the fact that the mother is taking one thing or the other. Though those ones maybe take that one as a history as possibly causing some general abnormality. That's why we take other abnormalities. So if it is due to teratogenic effects, what we mean by that toxic effect of what the mother is taking is likely going to cause other problems apart from clubfoot. But this idiopathic clubfoot we are talking about, it has nothing to do with whether the mother has attended an antenatal clinic or not. It just comes. Though there are different theories that they were postulated to back up, they are just theories. None of them has actually been established. We talk about maybe genetic predisposition because it has been linked that mothers or parents that have clubfoot, some of them have predilection of tendency to have children with clubfoot, and they told some a relationship between twin gestation between twin babies are also being established. However, all of these are they are just postulations. There is no established cause of idiopathic clubfoot, so it has nothing to do with patients' mother going for antenatal clubfoot. So uh, babies are born, no cause, no established reasons. It's just there. So idiopathic means there is no known cause as of now.
But how effective is prenatal screening to detecting whether a child, has club foot? And do you think this screening can help with at least helping with this situation?
Detects clubfoot in utero before birth through ultrasound screening. Ultrasound can actually pick it up.
Hello?
Hello.
Okay. Did you hear my
So
question?
yes, I said that it's possible to detect to diagnose clubfoot in utero before birth. By the time the patient is reaching the third trimester, when the musculoskeletal system are they are well formed, it's possible to detect and diagnose it before birth. So prenatal screening can actually detect the presence of clubfoot in an unborn child. Yes.
Interesting. And in solving it generally, do you think that the cost of treatment, is fair for people who are of underserved communities?
Yeah, thank you very much. The treatment of clawfoot has gone through different shapes. Historically, it has gone right even from the time of the father of medicine, Hippocrates, and different forms of treatment style has been adopted, starting from strapping the leg, stretching the leg, up to even surgical approaches, which have been flounced with a lot of complications, such as painful feet at the end of the surgery, to stiffness of the foot, and of course, non-functionality of the foot. So eventually, we had to go back to the conventional, the non-operative method, which has to do with manipulating the foot and then application of POP. And different people have worked on this until the last person who we call Ponseti, Ignacio Ponseti, of whose birthday we celebrate the World Love Food Day, which just happened yesterday, 3rd of June. Every year, that's the day for celebration of cloth. Why are we celebrating? Because cloth food is treatable. Now, based on Ponseti treatments, there are three levels to the treatment. He had a breakthrough in the treatment of this clawfoots due to his efforts he made into research. He went to cadaveric research and microscopic research and discovered that the treatment of the pathological basis of clawfoot is such that the structures in the foot of the patient is elastic in nature, especially the posteromedial aspect of the foot, compared to unlike the normal patients that don't have such structures. And so elastic nature means it can be stretched and get to the elastic limits, regain some stretchability and stretch again and stretch again. And based on this, it based its treatment on what we call manipulation and serial casting with plaster of Paris. So on weekly basis, patient comes, we will have the stretching of what we call manipulation, and where it's corrected to, you maintain it with plaster of Paris. The following week, patient comes, we remove the plaster of Paris, we stretch further, we maintain the gained corrected position with plaster of Paris, and so on like that. Between 5 to 8 weeks, it's three of the components are corrected before we now move to the second phase of the treatment, which is tenotomy. Tenotomy involved the cutting of the tendon at the back of the leg, which prevents the upward turning of the foot. So when that is cut, the equinox, the bending forward, the downward of the foot is correct, and the patient can now bring his foot up and place it on the foot flat. And then when this corrected, we have the casting done for another 3 weeks. The question will be that when the tendon is cut, what happened to the gap that is created? Study have shown that, experience have shown that the gap will always be filled with new tendon tissue, and then the continuity will be re-established. And after that, about three weeks, the healing of the tendon occurs. And the last stage of the treatment is application of what we call foot abduction brace. Is a kind of modified shoe that place the foot that have been corrected in exaggerated position. Why the exaggerated position? Because clubfoot, the greatest complication of this clubfoot is recurrence. It tends to come back, like I told you, the elasticity of the nature clubfoot back. So the foot abduction brace, which is the modified shoe, is very important to keep the foot in that corrected, in fact, over-corrected position, so that in case there are some tendency to recur, it will just bring it to the normal position. So we tend to put it in that. For the next 3 months, patient will have to be wearing this shoe for 3 months, almost 24 hours. Just give like 1 hour break for caring of the patient, grooming of the patient, perineal care, and sometimes the exercises, foot exercises. After 3 months, patients continue to wear this shoe every night. All of this will continue. I mean, this will continue until patient is up to like 4 to 5 years. At that point, it has been noted that the rate of recurrence is reduced at that moment. So a lot of education is very important at this point. In terms of affordability of the treatment being not surgical is actually likely to be more affordable. And one of the goal of Ponseti is actually to present a treatment method that is affordable to especially the resource constrained country. However, not all patients are still be able to afford these treatments. Some still have financial constraint in terms of affordability of this POP material on what weekly basis. And of course, the shoe, if you are to talk about the shoe, now the modified shoe, which I call foot abduction brace, it may go up to like 30 to 40,000. Not everybody can afford it. And then we have to be changing this foot because the patient's foot is growing. So when the foot catch up or it outgrows the foot, the brace, it have to be changed. Not all patients or not all parents can afford this. So that is why that's where the problem is and some of the limitation we are having, and that's one of the causes of the clinic dropout from our patient. But thanks to organizations, the national non-governmental organization like one based in Nigeria called Positive Care and Development Foundation. They have come in to help our patient and even help us to achieve our aim in treating this patient. PCDF for short that I just mentioned now, they have in other centers and to help our patients financially. They provide the materials that are being used to treat this patient, almost all the materials. Laws, they also provide them, but maybe in case they get exhausted, ask patient to buy. But the major materials, in fact, all the materials, apart from what I just said now, the POP, the soft band, the corticotomy, the tenotomy, the small surgical procedure I talked about, the materials, even the brace, they provide everything for the patient. So they have made the management of this patient seamless for us. They even go to the length of provide subsidizing their transportation for those who cannot afford transportation. And apart from that, through them, we have been able to form a formidable team of therapists that are managing these patients on a weekly basis. The therapists are multidiscipline, cut across different disciplines in the hospital, the consultant, orthopedic surgeon, the physiotherapist, the orthopedic nurse, the orthotics and prosthetics. So we have come together, and we also have a digital data collection session units that are for data entry. So they are upgraded the management of these Clubfoot treatments. And so our patients are finding it difficult. I mean, they're not finding it as difficult as before to obtain and achieve and sustain treatment of their patients, of their babies. Thank you.
Dr. Anipole Akeem, many thanks for your time. We truly appreciate it. I wish I would have actually had some more time to ask about the cultural beliefs and the traditional and cultural sentiments that comes with the courses of Clubfoot that would make people, not go further with the treatment. And I'm sure that in due course we would have you come back again to discuss this. Many thanks for your time. We truly appreciate it.
Thank you very much. Thank you very much.
We're back after the short break. Do stay with us.